a WikiVidi Documentaries production. Don't forget to like and subscribe. Enjoy.
Cannabis, drug. Cannabis, also known as marijuana among other names, is a psychoactive drug from the cannabis plant used for medical or recreational purposes. The main psychoactive part of cannabis is tetrahydrocannabinol, one of 483 known compounds in the plant, including at least 65 other cannabinoids. Cannabis can be used by smoking, vaporizing, within food, or as an extract. Cannabis has mental and physical effects such as creating a high, or stoned, feeling, a general change in perception, heightened mood, and an increase in appetite. Onset of effects is within minutes when smoked, and about 30 to 60 minutes when cooked and eaten. They last for between 2 and 6 hours. Short-term side effects may include a decrease in short-term memory, dry mouth, impaired motor skills, red eyes, and feelings of paranoia or anxiety. Long-term side effects may include addiction, decreased mental ability in those who started as teenagers, and behavioral problems in children whose mothers used cannabis during pregnancy. Studies have found a strong relation between cannabis use and the risk of psychosis, though the cause and effect relationship is debated. Cannabis is mostly used for recreation or as a medicinal drug, although it may also be used for spiritual purposes. In 2013, between 128 and 232 million people used cannabis. It is the most commonly used illegal drug both in the world and the United States. The countries with the highest use among adults as of 2018 are Zambia, the United States, Canada, and Nigeria. In 2016, 51% of people in the United States had ever used cannabis. About 12% had used it in the past year, and 7.3% had used it in the past month. The earliest recorded uses date from the 3rd millennium BC. Since the early 20th century, cannabis has been subject to legal restrictions. The possession, use, and sale of cannabis is illegal in most countries of the world. Medical cannabis refers to the physician-recommended use of cannabis, which takes place in Canada, Belgium, Australia, the Netherlands, Germany, Spain, and 31 U.S. states.
Medical
cannabis, or medical marijuana, can refer to the use of cannabis and its cannabinoids to treat disease or improve symptoms. However, there is no single agreed-upon definition. The rigorous scientific study of cannabis as a medicine has been hampered by production restrictions and other federal regulations. There is limited evidence suggesting cannabis can be used to reduce nausea and vomiting during chemotherapy, to improve appetite in people with HIV/AIDS, and to treat chronic pain and muscle spasms. Its use for other medical applications is insufficient for conclusions about safety or efficacy. Short-term use increases the risk of both minor and major adverse effects. Common side effects include dizziness, feeling tired and vomiting. Long-term effects of cannabis are not clear. Concerns include memory and cognition problems, risk of addiction, schizophrenia in young people, and the risk of children taking it by accident.
Recreational
cannabis has psychoactive and physiological effects when consumed. The immediate desired effects from consuming cannabis include relaxation and euphoria, a general alteration of conscious perception, increased awareness of sensation, increased libido, and distortions in the perception of time and space. At higher doses, effects can include altered body image, auditory and/or visual illusions, pseudo-hallucinations, and ataxia from selective impairment of polysynaptic reflexes. In some cases, cannabis can lead to dissociative states such as depersonalization and derealization. Some immediate undesired side effects include a decrease in short-term memory, dry mouth, impaired motor skills, and reddening of the eyes, aside from a subjective change in perception and mood. The most common short-term physical and neurological effects include increased heart rate, increased appetite and consumption of food, lowered blood pressure, impairment of short-term and working memory, psychomotor coordination, and concentration. Some users may experience an episode of acute psychosis, which usually abates after 6 hours, but in rare instances, heavy users may find the symptoms continuing for many days. A reduced quality of life is associated with heavy cannabis use, although the relationship is inconsistent and weaker than for tobacco and other substances. It is unclear, however, if the relationship is cause and effect. Spiritual. Cannabis has held sacred status in several religions. It has been used in an entheogenic context, a chemical substance used in a religious, shamanic, or spiritual context in India and Nepal since the Vedic period dating back to approximately 1500 BCE, but perhaps as far back as 2000 BCE. There are several references in Greek mythology to a powerful drug that eliminated anguish and sorrow. Herodotus wrote about early ceremonial practices by the Scythians, thought to have occurred from the 5th to 2nd century BCE. In modern culture, the spiritual use of cannabis has been spread by the disciples of the Rastafari movement who use cannabis as a sacrament and as an aid to meditation. The earliest known reports regarding the sacred status of cannabis in India and Nepal come from the Art of Aveda, estimated to have been written sometime around 2000–1400 BCE. Short-term. Acute effects may include anxiety and panic, impaired attention and memory, an increased risk of psychotic symptoms, and possibly an increased risk of accidents if a person drives a motor vehicle while intoxicated. Short-term cannabis intoxication can hinder the mental processes of organizing and collecting thoughts. This condition is known as temporal disintegration. Psychotic episodes are well documented and typically resolve within minutes or hours. There have been few reports of symptoms lasting longer. According to the United States Department of Health and Human Services, there were 455,000 emergency room visits associated with cannabis use in 2011. These statistics include visits in which the patient was treated for a condition induced by or related to recent cannabis use. The drug use must be implicated in the emergency department visit, but does not need to be the direct cause of the visit. Most of the illicit drug emergency room visits involved multiple drugs. In 129,000 cases, cannabis was the only implicated drug. Marijuana is the most common illegal drug reported in motor vehicle accidents. A 2012 meta-analysis found that cannabis use was associated with an increased risk of being involved in a motor vehicle crash. A 2016 review also found a statistically significant increase in crash risk associated with marijuana use, but noted that this risk was of low to medium magnitude. The increase in risk of motor vehicle crash for cannabis use is between 2 and 3 times relative to baseline, whereas that for comparable doses of alcohol is between 6 and 15 times. Long-term. Heavy, long-term exposure to marijuana may have biologically based physical, mental, behavioral and social health consequences and may be associated with diseases of the liver, lungs, heart, and vasculature. It is recommended that cannabis use be stopped before and during pregnancy, as it can result in negative outcomes for both the mother and baby. However, maternal use of marijuana during pregnancy does not appear to be associated with low birth weight or early delivery after controlling for tobacco use and other confounding factors. A 2014 review found that while cannabis use may be less harmful than alcohol use, the recommendation to substitute it for problematic drinking is premature without further study. Other side effects include cannabinoid hyperemesis syndrome. A limited number of studies have examined the effects of cannabis smoking on the respiratory system. Chronic heavy marijuana smoking is associated with coughing, production of sputum, wheezing, and other symptoms of chronic bronchitis. The available evidence does not support a causal relationship between cannabis use and chronic obstructive pulmonary disease. Short-term use of cannabis is associated with bronchodilation. Cannabis smoke contains thousands of organic and inorganic chemical compounds. This tar is chemically similar to that found in tobacco smoke. and over 50 known carcinogens have been identified in cannabis smoke, including nitrosamines, reactive aldehydes, and polycyclic hydrocarbons, including benzopyrene. Cannabis smoke is also inhaled more deeply than is tobacco smoke. As of 2015, there is no consensus regarding whether cannabis smoking is associated with an increased risk of cancer. Light and moderate use of cannabis is not believed to increase risk of lung or upper airway cancer. Evidence for causing these cancers is mixed concerning heavy, long-term use. In general, there are far lower risks of pulmonary complications for regular cannabis smokers when compared with those of tobacco. A 2015 review found an association between cannabis use and the development of testicular germ cell tumors, particularly non-seminoma TGCTs. A 2015 analysis of 6 studies found little evidence that long-term or regular cannabis smoking was associated with lung cancer risk, though it could not rule out whether an association with heavy smoking exists. Another 2015 meta-analysis found no association between lifetime cannabis use and risk of head or neck cancer. Combustion products are not present when using a vaporizer, consuming THC in pill form, or consuming cannabis foods. There is concern that cannabis may contribute to cardiovascular disease. As of 2018, evidence of an association is unclear. Cannabis is believed to be an aggravating factor in rare cases of arteritis, a serious condition that in some cases leads to amputation. Because 97% of case reports also smoked tobacco, a formal association with cannabis could not be made. If cannabis arteritis turns out to be a distinct clinical entity, it might be the consequence of vasoconstrictor activity observed from delta-8 THC and delta-9 THC. Other serious cardiovascular events including myocardial infarction, stroke, sudden cardiac death, and cardiomyopathy have been reported to be temporally associated with cannabis use. Research in these events is complicated because cannabis is often used in conjunction with tobacco and drugs such as alcohol and cocaine. These putative effects can be taken in context of a wide range of cardiovascular phenomena regulated by the endocannabinoid system and an overall role of cannabis in causing decreased peripheral resistance and increased cardiac output, which potentially could pose a threat to those with cardiovascular disease. There is some evidence from case reports that cannabis use may provoke fatal cardiovascular events in young people who have not been diagnosed with cardiovascular disease. Smoking cannabis has also been shown to increase the risk of myocardial infarction by 4.8 times for the 60 minutes after consumption. Neuroimaging. Although global abnormalities in white matter and gray matter are not associated with cannabis abuse, reduced hippocampal volume is consistently found. Amygdala abnormalities are sometimes reported. Although findings are inconsistent, preliminary evidence suggests that this effect is largely mediated by THC, and that CBD may even have a protective effect. Cannabis use is associated with increased recruitment of task-related areas, such as the dorsolateral prefrontal cortex, which is thought to reflect compensatory activity due to reduced processing efficiency. Cannabis use is associated with downregulation of CB1 receptors. The magnitude of downregulation is associated with cumulative cannabis exposure and is reversed after 1 month of abstinence. There is limited evidence that chronic cannabis use can reduce levels of glutamate metabolites in the human brain. Cognition. A 2015 meta-analysis found that, although a longer period of abstinence was associated with smaller magnitudes of impairment, both retrospective and prospective memory were impaired in cannabis users. The authors concluded that some, but not all, of the deficits associated with cannabis use were reversible. A 2012 meta-analysis found that deficits in most domains of cognition persisted beyond the acute period of intoxication, but was not evident in studies where subjects were abstinent for more than 25 days. Few high-quality studies have been performed on the long-term effects of cannabis on cognition, and results were generally inconsistent. Furthermore, effect sizes of significant findings were generally small. One review concluded that, although most cognitive faculties were unimpaired by cannabis use, residual deficits occurred in executive functions. Impairments in executive functioning are most consistently found in older populations, which may reflect heavier cannabis exposure, or developmental effects associated with adolescent cannabis use. One review found 3 prospective cohort studies that examined the relationship between self-reported cannabis use and intelligence quotient. The study following the largest number of heavy cannabis users reported that IQ declined between ages 7-13 and age 38, poorer school performance, and increased incidence of leaving school early were both associated with cannabis use, although a causal relationship was not established. Cannabis users demonstrated increased activity in task-related brain regions, consistent with reduced processing efficiency. Psychiatric. At an epidemiological level, a dose-response relationship exists between cannabis use and risk of psychosis. Although the epidemiological association is robust, evidence to suggest a causal relationship is lacking. Cannabis has also been associated with an earlier onset of psychosis. It is not clear whether cannabis use affects the rate of suicide. Cannabis may also increase the risk of depression, but insufficient research has been performed to draw a conclusion. Cannabis use is associated with increased risk of anxiety disorders, although causality has not been established.
Reinforcement disorders.
About 9% of those who experiment with marijuana eventually become dependent according to DSM-4 criteria. A 2013 review estimates daily use is associated with a 10–20% rate of dependence. The highest risk of cannabis dependence is found in those with a history of poor academic achievement, deviant behavior in childhood and adolescence, rebelliousness, poor parental relationships, or a parental history of drug and alcohol problems. Of daily users, about 50% experience withdrawal upon cessation of use, characterized by sleep problems, irritability, dysphoria, and craving. Cannabis withdrawal is less severe than withdrawal from alcohol. According to DSM-4 criteria, 9% of those who are exposed to cannabis develop cannabis use disorder, compared to 20% for cocaine, 23% for alcohol, and 68% for nicotine. Cannabis abuse disorder in the DSM-4 involves a combination of DSM-4 criteria for cannabis abuse and dependence, plus the addition of craving, minus the criterion related to legal troubles. Mechanism of action. The high lipid solubility of cannabinoids results in their persisting in the body for long periods of time. Even after a single administration of THC, detectable levels of THC can be found in the body for weeks or longer. A number of investigators have suggested that this is an important factor in marijuana's effects, perhaps because cannabinoids may accumulate in the body, particularly in the lipid membranes of neurons. Not until the end of the 20th century was the specific mechanism of action of THC at the neuronal level studied. Researchers have subsequently confirmed that THC exerts its most prominent effect via its actions on 2 types of cannabinoid receptors, the CB1 receptor and the CB2 receptor, both of which are G-protein-coupled receptors. The CB1 receptor is found primarily in the brain as well as in some peripheral tissues, and the CB2 receptor is found primarily in peripheral tissues, but is also expressed in neuroglial cells. THC appears to alter mood and cognition through its agonist actions on the CB1 receptors, which inhibit a secondary messenger system in a dose-dependent manner. These actions can be blocked by the selective CB1 receptor antagonist rimonabant, which has been shown in clinical trials to be an effective treatment for smoking cessation, weight loss, and as a means of controlling or reducing metabolic syndrome risk factors. However, due to the dysphoric effect of CB1 receptor antagonists, This drug is often discontinued due to these side effects. Via CB1 receptor activation, THC indirectly increases dopamine release and produces psychotropic effects. Cannabidiol also acts as an allosteric modulator of the mu and delta opioid receptors. THC also potentiates the effects of the glycine receptors. It is unknown if or how these actions contribute to the effects of cannabis.
Brought to you by WikiVidi Documentaries. Would you like to know more?